Hi, my name is Samantha Hintosh, and I'm a third-year medical student from McGovern Medical School. Today, I'll be presenting on a case of mast cell activation syndrome. This syndrome is actually on a spectrum of mast cell dysfunction diagnoses ranging from mast cell activation syndrome, or MCAS, to mast cell leukemia. Of all the mast cell disorders, MCAS is often the most difficult to diagnose due to its lack of uniform symptoms and community agreement on diagnostic factors. MCAS has features such as a normal mast cell count, mast cell infiltration into extracutaneous organs, and multi-system comorbidities, all highlighted by chronic inflammation. Here we present a patient who has clear ENT diagnoses, but who upon further investigation has a unique set of multi-system comorbidities attributable to systemic dysfunction of mast cells. The patient is a 51-year-old male who presented with complaints of right nasal obstruction and sinus pain for at least 10 years. Other ENT diagnoses included asthma, allergic rhinitis, and obstructive sleep apnea. On physical exam and endoscopic interrogation, he had a deviated septum and nasal polyps and was subsequently diagnosed with chronic rhinosinusitis with nasal polyposis. On further investigation into his past medical history, he had many other diagnoses across body systems that at first don't appear to be part of the clinical picture. He had dermatologic findings such as angioedema and dermatographia. He had GI findings such as GERD with Barrett's esophagus, eosinophilic esophagitis, and chronic gastritis. He had urologic complaints such as chronic non-bacterial prostatitis, and even neurologic findings such as paresthesias and fasciculations. These multi-system findings prompted a study of the patient's tryptase level, which was trended over 5.5 years. Tryptase is a highly sensitive marker for mast cell function. His was found to be an average of 15 nanograms per milliliter. A normal range is usually defined as 2 to 10 nanograms per milliliter. Other elevated values included his IgE. Subsequently, due to concern for mast cell leukemia or systemic mastocytosis, a bone marrow biopsy and DNA sequencing were done. Bone marrow biopsy revealed no abnormalities. The concern was that there would be a more than 20% infiltration of atypical mast cells, which would have confirmed a diagnosis of mast cell leukemia. DNA sequencing of the c-KIT gene revealed no signature mutations commonly associated with systemic mastocytosis, specifically on codon 816. Collectively, the persistently high tryptase and IgE values combined with a normal c-KIT gene were consistent with a diagnosis of MCAS. The patient's clinical course was notable for sinus surgery with polyp removal after a failed trial of medical therapy. The inflamed sinonasal tissue was immunostained for tryptase, which showed mast cells concentrated in the mucosa. Overall, his ENT symptoms have been well controlled with saline irrigations, momentosome, and quercetin, which is a mast cell stabilizer. Notably, many of his other symptoms have also responded well to the quercetin, further implicating those other findings and diagnoses as part of this syndrome. In conclusion, it cannot be determined that his mast cells imply a causative role in the pathogenesis of these patients' ailments. But with clear guidelines for the diagnosis of MCAS and a better understanding of the complex inflammatory response, we hope to lead to better treatment and care for patients with a complex clinical picture related to mast cell dysfunction. Thank you all for listening. I appreciate the opportunity to share my work.